It is my pleasure to introduce Dr. Joan Beckman, a physician scientist and assistant professor at the University of Minnesota, who will talk to us about a topic that was a popular, high-in-demand topic that the patient committee wanted to hear. It is on anti-thrombotic therapy in myeloproliferative neoplasms. Dr. Beckman, the floor is yours.
All right. Well, I want to thank everyone for the invitation. And so I have some learning objectives here, and some of these I'm going to go over fairly quickly for this audience because I had an excellent setup. But why do we worry about thrombosis is one of the main things. How can it be prevented? And then how can we treat? So those are the three main things. And when I'm sitting in front of a patient, these are sort of what I go over. And so I actually do a lot of coagulation outside of the MPN space, and I think it's just Thrombosis Awareness Month. 600,000 to 900,000 Americans have a DVT annually, and about 100,000 of them die. And some of these deaths occur very quickly after diagnosis, and 1 in 5 is related to a cancer. So this isn't just MPN, but other types of cancers as well. But thrombosis is the leading driver of mortality and morbidity in our patients, and it's a 20% prevalence by the time of diagnosis. And I think for many, we think of venous thrombosis, but I also consider arterial thrombosis to be thrombosis, and so those are our strokes, our heart attacks. But then there's also venous thrombosis in splanchnic veins, as illustrated here in this cartoon, but also lower extremity DVTs, PEs. And the 10-year probability that you'll develop a fatal cardiovascular event is actually higher than the probability of dying from MPN blast crisis. So when I'm sitting in front of a patient, I'm not just thinking about their risk of transformation, I'm thinking about their lipids, I'm thinking about their risk of having a cardiac event. For this audience, this slide probably doesn't need to be in here, but I did include it just because thrombosis risk does tend to travel a little bit with our mutational status. So individuals with the JAK2 V6-7F have a high prevalence of thrombosis. However, individuals with CALR are not immune from this in that they still have an increased risk of thrombosis compared to individuals who have no mutation alone. So individuals who present with thrombocytosis or other reasons. A few years ago, one of my colleagues, Brenda Reeves, and I sat down and said, what could be a mechanism related to coagulation activation? What drives coagulation? So we all know that the stem cell has JAK2 in this individual. And from that, our myeloid cells, our leukocytes, and other cells have these. We know that we have excess production of cells, and this leads to a pro-inflammatory environment, much like our last talk talked about. There's over 79 different cytokines. Some of them are pro-inflammatory, some of them are actually anti-inflammatory. Histamine, thromboxane, all these other things that are just being secreted into your blood. It goes down to this blood vessel layer, and what you get is on that blood vessel, you can actually have the mutant cells in the blood vessels, so those are the green ones there. But you can also have expression of these things like what we call tissue factor, which is one of the coagulation pathways enzymes. These activated leukocytes, red blood cells, and platelets in increased numbers or even in decreased numbers stick to that activated blood vessels, and leads to this sort of formation of a perfect storm where you get this blood clot formation. Now, in some individuals, and we don't go into this too much today, there's also hemorrhage, and that would be a whole other talk for a whole other day. So we acknowledge that there's this role of the stem cell and the role of this mutations, but what are we able to do about it? So there has been some risk calculators made. One is the IPSIT score. This is mainly for our peers that have ET. And so what we're able to do is calculate your age, your prior thrombosis risk, your cardiovascular score, and your mutational status, and we can pop out a number saying you're at this increased risk for thrombosis or not. For PV, we tend to simplify it a little bit more. It's age, mutational status, cardiovascular history, and it can be yours or your family's, and your hematocrit. What you can see here is that age is a common theme, older versus younger. And I hate sitting there and saying to someone who's a robust, viral 60-year-old that you're old, but that's what this calculator tells me to do. So I try to use better language than that. So we have different ways to prevent or treat MPN thrombosis, and I sort of line them into two buckets because it's easier for me to walk and talk through them this way. So first is to target the coagulation pathways, and I spared you guys the big diagram of all the coagulation pathways, but we'll start with the one that's been around the longest, aspirin. Many of you are probably on this drug. And then cytoreductive options. And I have an asterisk here because phlebotomy is like manual cytoreduction. We're just literally removing cells there. And these two have a lot of data, but there's other ones. So there's other antiplatelet agents, and there's a long list of names here: clopidogrel, ticagrelor, prasugrel, xylitol. They have trade names. And then there's the warfarin, which has been around for a long time. And then there's the direct oral anticoagulants. And here I'm lumping together rivaroxaban, apixaban, edoxaban, and dabigatran. And some of you guys may be on these drugs as well. For our cytoreductive options, many of these have just been touched on. We have hydroxyurea. We have the JAK-STAT inhibitors. And again, there's many of these that have been approved in the last few years. And then we have the interferons. And what we know is that the actual evidence for thrombosis risk reduction is kind of highest for the ones that have been around the longest and lower for the ones that are newer to the game. And so how we use these in the setting of MPN is sometimes a matter of debate or a matter of sort of personal preference. So I want to just sort of briefly touch on the data for aspirin and bloodletting, which is sort of what we've been doing for a long time. And I think highlight this recent trial. This was an ARIES trial going after the debate: do you take aspirin once a day or do you take it twice a day? Note this was for baby aspirin, not the 325 aspirin. What was interesting about this trial is they used a surrogate biomarker, serum thromboxane. Now, I have yet to have a patient come in and go, my serum thromboxane is high. If they do, I'd be excited and talk about that with them. But it's a surrogate biomarker for platelet activity. And what they showed is that using twice-a-day aspirin reduced that endpoint. But I think for those of you in the room that are patients, and for me as a treater, I also want to know, how does it make the patients feel? Is there a difference with the once a day versus twice a day? Because obviously nothing is, every treatment has an equal and opposite reaction. And then if I'm making you sick from taking aspirin twice a day with gastritis, that's not great. But in this trial, they did see a reduction in the MPN symptom assessment score. And what I found fascinating is when you looked at this, when they looked at arterial thrombosis, there was no difference. Minor thrombosis, there was no difference. Clinically relevant non-major bleeding, there was no difference. But the microvascular symptoms were the ones that had difference. So my patients that have prominent microvascular symptoms that I really am concerned about, I'll say, let's try our aspirin twice a day and see if it makes a difference. It's really, you need to ask about it. We talk about phlebotomy. There's trials showing that reducing the hematocrit, lower, a more extreme target of 42% versus 45%, does prevent thrombosis. That's death and also from cardiovascular events. But is this for everyone, or is this just for some of our patients? And I think this is sort of the stratification and the sort of delineating that you're all unique individuals and have unique characteristics. Lower hematocrit's better for some, and in particular, people who are somewhat older in age, have higher risk cardiovascular profile, have normal platelet counts, no splenomegaly, no diabetes, have maybe some elevated blood pressure. They are using aspirin and they're not on anticoagulation. These are the people who did the best in these trials. So that's something to think about. Do we really need to drain the essence from everyone to get them down to that lower hematocrit, or can we be a little more sophisticated about that? Now, hydroxyurea also has substantial benefits in that it has been shown in trials to reduce the risk of thrombosis, at least in polycythemia vera. This was done a number of years ago. And it also has, it looks like, and these trials all have their variance nuances that, we could argue against or for, but in the ET space, there's also some benefit that has been shown, though the comparisons have been a little bit different. Now, the JAK-STAT inhibitors are interesting because they are fundamentally targeted, but they're also sort of grossly anti-inflammatory. And in fact, JAK-STAT inhibitors as a class are also used for many other diseases, not ruxolitinib, but other JAK-STAT inhibitors are used for ulcerative colitis. They're used for rheumatologic conditions as well as dermatologic conditions. And incidentally, in the rheum and inflammatory bowel syndrome space, one of the prominent JAK-STAT inhibitors actually has a black box warning against thrombosis. So asking this question is actually important. So there has been several meta-analysis that has shown that compared to best available therapies in these trials, there was a reported reduction in thrombosis risk in patients who are on ruxolitinib compared to standard of care. This was not a significant difference in terms of thrombosis risk reduction, but it was a reported decrease, and this was in older numbers. There's been subsequent papers that have shown that exposure-based thrombosis rates are lower in patients who are on ruxolitinib versus best available therapy. And in fact, patients had a benefit when they did a crossover as well. So this is with ruxolitinib. We don't have data for the other JAK-STAT inhibitors because that's typically not an endpoint in those trials spaces, but we may get this as there's been more post-marketing data for these. And then for interferon, I think interferons have been used for a long time, and we have a lot of different sort of potential mechanisms where interferon may reduce thrombosis risk, namely through potentially reducing inflammation. But when we look at patient-related data, in the ET space and the PV space, there's sort of a mixed signal. It looks like in the PV space, there's some reduction. In the ET space, it's sort of maybe not as great. But I think it's worth noting that in the continuation study, there was a reduction. Now, this may be due to reduction in variant allele frequency as well. So is the interferon actually biologically affecting the inflammation or reducing the variant allele frequency? We don't have the answers to that. And in fact, my research lab is approaching this as a sort of research questions to evaluate how these inhibitors reduce thrombotic risk. And so we have an ongoing registry and prospective study to identify biomarkers to help identify patients. And then we're doing things like microfluidic models using our patient samples and developing mouse models to address these questions. I'll spare you all these details, but we'll go into that. But I wanted to spend more time on how do we treat thrombosis, because I think this is when I'm sitting in front of patients, the thing that and they ask about my research and I tell them about it, but this is where they're at, is how do we treat these? And so how do I approach this as a coagulation specialist? So clots in atypical locations mean that we don't have a lot of data. So splanchnic vein clots, cerebral venous sinus thrombosis, those are atypical locations. And so we don't have a large number of data for these. And we're working on this through international collaborations on the splanchnic vein space to really explore this. And then pulmonary embolisms and DVTs, if you've had one, they're not fun. They're not great. I actually send people to rehab for pulmonary embolisms. I send them to post-traumatic stress people when they have pulmonary embolisms because it can be very scary. And so I think it's good to know that not all clots are created equal. Are they arterial or are they venous? Are they provoked or are they unprovoked? Is it the classic, I traveled to someplace on an airplane for multiple hours and then I had my clot, or is it that I woke up not feeling great and I was diagnosed? What's the location? Do you have symptoms? And are the symptoms persistent? Do you still have a big swollen leg with post-thrombotic syndrome? Do you still have shortness of breath? Do you still have chest pain? And what other comorbidities are driving some of these factors? These are all things that we are not really great at in the thrombosis world in general, but also in the MPN thrombosis space. Now, antiplatelet and antithrombotic treatments are used, obviously. What I can say is when you look at the data, there's less data for using the antiplatelet agents like clopidogrel, ticagrelor, prasugrel, or ciastol in these patients. Aspirin's sort of the one that leads. But obviously our patients are being put on these antiplatelet agents. We just haven't systematically done a trial, randomized control trials in this space. Warfarin's been used for many years, and then the direct oral anticoagulants are increasingly becoming more frequently used. And in particular, I want to say that the two that are most commonly used are the rivaroxaban and the apixaban for a lot of reasons. There's less data for endoxaban and dabigatran. So when I refer to direct oral anticoagulants or DOACs, I'm usually referring to those. Now what's striking is that despite prophylaxis with vitamin K antagonists or warfarin or DOACs after venous thrombosis, there's still a lot of work to do. There's still a gap where patients are still having an increased rate of thrombosis. And why is that? Now, it could be because the therapies alone are just not addressing the disease, right? If we're treating an inflammatory disease with something that just covers coagulation, we're not covering the inflammation. So if you look at the data for antiplatelet alone, oral anticoagulation alone, oral anticoagulation plus antiplatelet agents, or no treatment, we see that there's basically some kind of baseline thrombosis risks. What's interesting is when you combine antiplatelet with cytoreduction, when you combine antiplatelet with oral anticoagulant, or if you add all three, there's actually a benefit. And it's not cumulative. So if you note here, having oral antiplatelet, oral anticoagulation and cytoreduction actually had sort of not as great outcome. And that could be because you compound the side effects. You have increased risk of bleeding. Now, direct oral anticoagulants are sort of a newcomer in the world of cancer thrombosis. Only since, when I was first in fellowship, it was easy. Oh, they have cancer? Just give them Lovenox. That was the answer. But as I've been in practice longer, now we can, based on these trials, use these direct oral anticoagulants, rivaroxaban and apixaban. But because of this, these trials were underrepresented for MPN. It's a rare disease. And so there's very few studies, actually no randomized trials that I'm aware of, that are assessing these anticoagulants in patients. And so when we look at single study data, use of dabigatran or Pradaxa or endoxaban was associated with somewhat higher risk of recurrent thrombotic event. And the rates of recurrent thrombosis were sort of ranging in that same 5 to 8% risk, but it was mainly driven by arterial events. And I'll say in my hat as a coagulation specialist, arterial thrombosis is tricky because DOACs do not seem to be sufficient, especially in other inflammatory diseases like antiphospholipid antibody syndrome. So how do I approach a thrombosis in a patient? So again, not all clots are created equal. If someone has a big splanchnic vein thrombosis, I'm going to be treating them differently than someone who has a pulmonary embolism or someone who has a distal DVT. But there's sort of a general framework that I sort of take up and that I teach to the fellows and to my residents when they're in my clinics. So first of all, if they have an obvious MPN, we want to sort of talk early about cytoreductive therapy, not just be like, oh, we're just going to treat with blood thinner and it will be fine. We don't need to start therapy. I talk early about a cytoreductive therapy. Especially if they have PV, I'm going to be sort of getting their hematocrit under control. In ET and PMMF patients, I don't target a specific platelet count, but I want to go for some reduction. And I actually do target a sort of try to get the white count lower based on data from my own lab and from increasing evidence that Dr. Hasselbach presented. If you have a superficial clot, so you've got an IV in and then you remove it and you have a clot there and it's not reached that deep vein level, I will maybe use fondaparinux, though it isn't an injection and injections aren't fun. Or I may use a DOAC, or I may just say, let's do some warm compresses and ibuprofen and treat it symptomatically. But if it's not getting better, we will continue to increase our treatment of that. And you end up getting a lot of ultrasound. So superficial clots are not necessarily a nuisance. They're not necessarily a nuisance because if you're having to go get multiple ultrasounds and get shots, that's a real thing. If you have a deep vein thrombosis, some people argue that distal versus proximal, but distal clots can be just as challenging because they can be painful. They're in your calf, it hurts to walk. And so I always do therapeutic dose anticoagulation. I do it for at least 90 days and I try not to interrupt it. So we're going to do 90 days of uninterrupted anticoagulation. After that 90-day point, then we have a discussion about what we're going to do about it. Same thing if you have a proximal clot or a pulmonary embolism. 90 days, 3 months. Then at that 3-month visit, we have to talk about what are we doing? What are we doing about your MPN? What are we going to do for your anticoagulation? So this is a proposed framework that was published recently in Blood, and I follow this somewhat. So if their MPN's under control, and say it was a provoked clot, say it was a young woman who had just started on oral contraceptive pills, and we found out they had an MPN at the same time. We get them on their MPN control. They still don't want to have a child. I may continue them on full dose anticoagulation so I can continue their estrogen therapy while treating their MPN. So those are sort of every situation we have to sort of think about uniquely. If their MPN's not controlled, say we haven't settled on the right therapy yet, say they had side effects from one and we've had to switch to another, or more commonly in the US, their insurance won't let me use what I want to use first line and we have to go through several other lines of therapy. These are things that we're working on during those first 90 days, but we may extend it, and if we're not in the right spot. Now, there's some data here that we don't have. One is, in the thrombosis era, there's just recently a New England Journal paper about using reduced dose DOACs. So taking that apixaban dose that you'd be taking 5 milligrams twice a day and reducing it to 2.5 milligrams twice a day. In people who don't have MPN, that has been shown to be non-inferior, meaning it prevents thrombosis. And in fact, in over 6 months, people that stayed on the extended anticoagulation had better outcomes. We don't have that same data for MPN. So we have some research or unmet needs here about how to treat patients. And then things that I don't have time to cover today is bleeding risk. Patients with MPN have risk for bleeding. And the number one side effect of blood thinners is bleeding. And, it can be anything from nosebleeds that last for a long time to major hemorrhages. And those aren't minor. It can be bruising that people are afraid that you're being abused. So we have to really sort of weigh the risk of bruising and bleeding and major bleeding with patients. I don't have time to get into interventional radiology interventions in particular for the splanchnic vein patients, so the use of dips and tips and those things, which one's better, that data. And I didn't cover thrombectomies and whether or not they're useful in this setting, though they're offered to many of our patients. And then again, I covered that the use of these lower dose of direct oral anticoagulants is really sort of an unexplored space where I have to dig deeper into the data that's out there and then also consider designing some prospective studies. So in summary, sort of, your clinical presentation, clot can be the first thing that makes you find out you have an MPN. Or you can have an MPN for years and then find out you have a clot. Either is not fun. And so I have a patient who has a new clot and I think, oh, they may have an MPN. I bring it up early and I will test for it. And we've caught several people in our thrombosis clinic that have low levels, sort of chip level of an MPN from that approach. If you have a known diagnosis, I'm always like, if your leg is swollen or feeling funky, something just doesn't feel right, you're more short of breath, let us know. An ultrasound is an easy thing to get. So I think some awareness of that risk is also important. I think in our clinics, we need to think about risk evaluation and doing that on a regular basis, either working with our primary care colleagues to make sure their lipids are checked, make sure their diabetes is under control, checking the blood pressure. So it's not just what are the counts, we have to look at the full picture, really sort of wear our internist hats when we're practicing as hematologists. And then which cytoreductive therapy and the intensity of cytoreductive therapy is important to sort of go hand in hand with our thrombotic coverage. And then what thrombotic strategy works, which anticoagulant, how long do we do anticoagulation? Can we interrupt anticoagulation? Do we need to add antiplatelet therapy? That's really sort of an individualized approach, but we have some data to support some of the strategies over others now. So final takeaways, the JAK2 mutation does place risk of thrombosis, but those of you who don't have that are still not immune. CHIP alone can also put you at that increased risk. Hematocrit goals and PV do reduce thrombosis risk. All MPN treatments likely offer some anti-thrombotic benefit, though they're not strong enough alone. They often need partners. And that dual treatment with cytoreductive and an anticoagulant or antiplatelet agent is likely appropriate for most patients that are at high risk. And there's less data, but growing evidence that direct oral anticoagulants with cytoreductions are safe. We just don't know about dosing yet, and I think some of those questions we won't have answers. So I'd like to thank the opportunity to present today and look forward to talking with you all during the patient section later.